Now we have to move on to our next session, that is Jeffrey C. Hall session. It is named after the scientist Jeffrey C. Hall, and who received the Nobel Prize in Physiology or Medicine in 2017 for the discovery of molecular mechanisms controlling the cardiac circadian rhythm. And I would like to introduce our chairpersons for this session, Dr. Arun Saxena, Dr. Bipin Amin, and Dr. Shushil from Ahmedabad. Our first topic is a duologue on the topic of real world experiences of people living with type 2 diabetes, language matters. So I would request Dr. Arun Saxena to introduce our speakers for the duologue.
Thank you very much for inviting me for this scientific session of Swasthyacon 2021. And today's our first topic is, Dr. Tejal Lathia. She is a consultant in Fortis, Apollo, MGM, Cloud9 Hospitals, and Navi Mumbai, and she is a consultant endocrinologist. Over to you, Dr. Tejal. Our second speaker would be Dr. Chitra Selvan. She is from MS Ramaya Hospital, Bangalore, and her designation is Associate Professor. Over to you, ma'am.
This is Dr. Chitra, and with me is Dr. Tejal Lathia, and we are here to discuss some of the work that we've done to highlight the impact of Language Matters movement in people living with type 2 diabetes with some real-world experience.
In this topic, we're going to, this is the agenda that we're going to discuss. Why is language important? What is the impact of language in patients with type 2 diabetes and where it intersects with obesity? And what can we do better? So most of us would think, why this topic? Is this something that we really want to know about? And the reason we want to discuss this topic is because it has a huge impact on the management of people living with type diabetes. So when you define language, language is the method of human communication, which is either spoken or written, consisting of the use of words in a structured and conventional way.
But it's important to recall that words have power. They do things, they change things. They transform not just the speaker, but also the hearer. They feed understanding and emotion back and forth and amplify it. What can language do, Tejal?
Yeah, so what you were saying is we define language, and it sounded like it was pretty simple, just communicating between two people. But what you said is it's so much more powerful than that. And I think it's powerful enough to either divide us or bind us. It can engender either happiness or despair. It can break trust or it can build trust.
But can I just play devil's advocate for a minute and ask you, Tejal? I'm already a busy practitioner in a clinic which is filled by more people than I can handle. And apart from that, I also have to now wear a mask and a face shield. And I also need to make sure that I'm not missing out the statin or the antihypertensive. I also try and get to that HbA1c target. On top of this, now you're telling me that I need to make sure that I mind my language. Isn't this a little too much of a burden to expect from a doctor? And how is this even going to help at all?
Well, I think one of the ways that, we can bridge the gap between what is now this huge divide between doctors and patients, where we don't seem to be able to have that trust connection anymore. And this leads to a lot of conflict, a lot of strife, and as you also know, violence against doctors. Right. So I love this quote by Mark Lewis, which he posted on Twitter, and we've taken permission from him to quote him again, that when we were learning to be doctors in medical school, all we were taught is how to make the diagnosis, how to do the treatment. But nobody, and simply nobody, told us that the hardest part would be convincing people of our good intentions, that what we are saying and doing is in their best interest. And it often seems to be that you're almost begging the person opposite to you to do it as a favor to you and not because it's good for their health.
And I think that's a sentiment which most doctors practicing in India, at least, would completely understand and appreciate. So we all know that when we say language, it's not just the words. When even amongst the words that come out of our mouth, the tone of your voice can affect the impact of your language, the inflection of your voice, how you go up and go low with that, the volume, whether it's booming or whether it's kind and soft, all of those are aspects of language that can change the way the person across us perceives what we are saying. Not only are those the only aspects about verbal language, there are also the other cues, like, for example, the way in which you're placing your hands across your body, whether you're looking them in their face or not, whether you're looking distracted, facing towards your computer screen, whether you're reaching out to your phone in the middle of their sentence, whether you're nodding your head or not, whether you're smiling, frowning, raising your eyebrows or a HbA1c. All of these are factors which makes the person sitting across us feel alienated or maybe not so safe and comfortable.
So, this is exactly what I meant, that it's not simple words alone, but the tone, inflection, the volume, and your body language and facial expression together. Somehow, this is what we describe in the English language as what is called as connotation, because the words may say one thing, but you may mean something completely different. So what connotation means is an idea or feeling that a word invokes for a person in addition to its literally or primary meaning. Just simple things like, oh, I'm so glad to see you, or oh, now you've come. So you understand just the fact that when the first sentence I say is like, oh, I'm so happy to see the person, and the second sentence which I said, it means that like, oh, now you found the time to come and visit your doctor now where everything has gone bad. So I think that the words alone do not give the entire message, and all of that entire package is important, and we must make sure that we give a positive connotation or a constructive connotation to most of the words that we use in communication with our patients.
Very well demonstrated, Dr. Tejal. So I think we've now at least understood that our patient spends maybe 10 to 15 minutes with us, maybe once in every 3 months, which amounts to maybe an hour with us over a year. But the words we say, the message we send out, the hope that we steal away or maybe give is the one which is probably going to impact the change in behavior, which is so crucial in the management of diabetes. So now we'll just pause a little bit and dwell a little deeper to understand some of the stories we've heard from our patients and what we learned from that conversation we had with our patients about their experience when they walk into a doctor's clinic. So, Dr. Tejal?
Yeah, so communicating the consequences of elevated blood glucose to people living with diabetes. Now, if you just analyze the heading that I've given, I talk about consequences of elevated blood glucose. I don't talk about complications of high blood sugar, because when you use the word complication, that in itself instills fear in patients. When you say high blood sugar, that also instills fear in patients. So I've very specifically put this section heading, communicating the consequences of elevated blood glucose to people living with diabetes. Please go ahead, Dr. Chitra. Yeah. So whenever you talk about, the consequence of high blood glucose or elevated blood glucose to your patient, now why are you doing this? Because whenever you see a person sitting in front of you with an HbA1c of 10%, you know what are the catastrophic consequences that this diabetes can have for this person. And in their best interest, you want to communicate to them that these are all the things that may happen to you if you do not manage your diabetes better. So what I want to underline here is that the intention of the doctor is for the benefit of the patient, because they know that what the future holds for this patient. So the next few words or sentences that you may use for the patient are intended to motivate this person, to familiarize them with the consequences of diabetes, and hope that they will, take the medicines well, they'll do the lifestyle modifications, and that is why you say what you do. But what do you really end up saying? And this is a word cloud which is generated from a survey we did of over 1,000 doctors treating diabetes across India. And we use words like side effects, amputation, complication, heart attack, this is a silent killer, impairment, damage. So we use blindness, we use a lot of words with negative connotations. And what we intended to do was motivate the patient, but this is what the patient ends up feeling. They feel despondent, they feel discouraged, they feel demotivated. They don't really want to do anything because all of the things that are being told to them sound so scary that it just doesn't seem to make any sense, to make any effort at all. So these are verbatim some of the things that our patients across the, when we were doing our research, patients have told us. And I remember this woman, she still comes to me. And she said, when I went to the doctor for the first time, the doctor scared me a lot. Their way of talking was such that I don't know what big thing has happened. The way of explaining was such that I panicked. And then whenever I visited the doctor, I was told that you will have a heart attack, your kidney will be damaged. Something or the other was always told to her. And she felt that this way of talking by doctors was not right because it affected them. Some of the other stuff that patients shared with us was that they felt that the doctor is the only person which has the full knowledge about diabetes. They do talk to other people, but they don't have the full knowledge. So when they come into the doctor's chamber, they're looking for comfort. They're looking for reassurance that this can be managed, and it can be managed as a team effort with the doctor. But the person who is talking to them does not comfort them, but keeps saying, oh, your sugars are so high, your sugars are so high. So this can be very demotivating for the patient. This is one of our patients. I can see her in front of my eyes, and this is what she said in such a strident tone, but that scolding as if you have committed a crime. So the way we speak, that tone of voice, the high volume and that inflection when we are scolding the patient can be really, really discouraging. Next, please. And this was a wonderful constructive way that one of my other patients, he's a chemical engineer, he still follows up with me. He says whatever the patient has to face, he has to face, and he knows that. But he wants that some kind of positive energy is created during the course of the conversation, and not a fear psychosis, which really kind of leads to paralysis rather than motivation. So what should we do as doctors when we want to communicate our intentions, but we want to do this in a positive manner and not in a way that creates fear psychosis? So these are some of the solutions that we came up with. So often when we speak to patients, we talk about something that will happen. That if your sugar is not controlled, you will get a heart attack, you will lose a limb, you will have failed kidneys. So this is something which sounds like it's inevitable. And the reason why it's important to not say it like this, because one of our patients told us, is because it takes away all hope. When you present something as inevitable, it equals something which is hopeless, and you may not want to start the task at all. You could just word this slightly differently, that if you manage your blood sugars well, you can live a life which is free of any untoward or unwanted consequences of diabetes. Or you could say that if you manage your sugars well, you can keep your eyes, your kidney, your heart absolutely safe. So try to word it in a way as to what you can avoid or how you can keep things safe, rather than kind of putting it in a way which hints at the fact that this is inevitable. Some of the other solutions that our patients themselves have given is paint a better future. And I still remember the patient who has said this. He still follows up with me. And he said the way you could put this is that, you know what, if you maintain an HbA1c below 7%, you may never have to face any complication of diabetes. Now, when you put it like this, that the patient will not have any complication of diabetes, it gives them hope, it motivates them, and it makes them want to comply with whatever you've told them to do. You could also say that I have seen so many patients who've managed their diabetes well, and they're living a great healthy life even after 20 to 30 years of diabetes. So I think that fear, which is something that we use to hang over our patient's head, just leads to paralysis and does not motivate the patient. Of course, I just want to add one last sentence here, that yes, there are some patients where fear works. And often when we speak to doctors, the first thing the doctor says is, you know what, I scared him and that's why he's now following up with me and he's doing everything right. But what you don't understand is that out of 10 people that you've scolded, it may happen that in a busy practice, just one comes back and 9 don't even come back to you. So that you really don't have any way of knowing that whether what you've done has been motivating or it has demotivated the patient and the patient has not gone back to see their doctor at all. So this is in brief about how you can communicate about elevated blood sugars to your patients and highlight the consequences of diabetes. Another place where there's an intersection of diabetes and communication is obesity. And Chitra, please go ahead and tell us a little bit more about this.
Thanks, Dr. Tejal, for that. So as endocrinologists and diabetologists, we are all very, very focused on handling obesity in the management of type 2 diabetes. We understand that bringing down weight can bring down even remission of diabetes. That is something that we're talking about now. We also know that it can bring down the dose of medications that your patient is on. It can also bring down the requirement of insulin dose, also maybe cardiovascular mortality in the long run. So there's a huge emphasis, and we know that you're coming from a good place when we want to talk about obesity. But for a person who's obese or overweight, trying to lead a normal life in the world, their perspective might be completely different. And these are screenshots of the character named Kate Pearson from the series This Is Us, which is on Disney Hotstar, I think. And this is probably one of the rare realistic depictions of what the life of a obese person is like. So notice here that she's taking her earrings off and she's bare naked before stepping onto her bathroom scales to check her weight early in the morning after she's voided her bladder and not even had a sip of water, because what that scale shows is equivalent to how she sees her own self-worth, right? That's the amount of baggage that goes into getting on a scale for a person who's battled obesity all or most of their life. Cut straight to what happens in your clinic when a person comes in with obesity and type 2 diabetes, right? So my waiting room is full most times, at least pre-COVID times. The weighing scale is a digital weighing scale, so the only place where I can fit it is in the waiting room. The room is full, and as soon as your patient walks in, my nurse or sister asks her to get on the scale. There is no guard to protect the number from being flashed to everybody in the waiting room to be seen. And right as she walks in, maybe my resident or somebody else sees her, and the first question they ask is, what was the weight that was measured outside, right? So for most people who are coming in to even seek help for weight, to begin the conversation with weight itself seems to take away everything else about them and just seems to push towards focusing on numbers. So people with obesity do have a whole lot of stigmatized behavior that they have been subjected to. Overall, numerous research has revealed that people do tend to think that people who are obese are lazy, they make bad food choices, they did it to themselves, and make it look like it is something about willpower or irresponsibility on that individual per se, and that obesity is not a disease at all. So there's already a whole lot of baggage that they come in with. So it takes very little, very, very little to tick them off. So this is what is referred to as weight stigma. It refers to negative behaviors and attitudes that are directed towards individuals solely based on their weight. Now, of course, we might all be making it all the efforts to make sure that we're not consciously being biased towards obese individuals, but some of it can be so ingrained and so implicit that we might be doing it completely unconsciously or involuntarily, which could be very subtle, which you and I might not pick up at all, but a person who is very, very sensitive to it will pick it up right away. It could just be the subtle that smirk in your face when she tells you her weight, or a subtle when you notice that the weight has gone up between last visit to this visit. And if you're thinking that this is just a first world problem, my patients who visit me in India definitely are not worried about weight stigma. This is a survey which was done across the globe, which looked at both explicit weight stigma and implicit weight stigma. And please understand that the prevalence of weight stigma is very, very high, even in a country like India, where we all tend to believe that our patients are not so sensitive. So let me just highlight one of the words which we very commonly use as a scientific adjective for obesity, right? We even grade obesity as morbid obesity. And this is how the Webster's Dictionary defines morbid as: characterized by an abnormal and unhealthy interest in disturbing and unpleasant subjects, especially death and disease. The second definition is abnormally susceptible to or characterized by gloomy and unwholesome feelings. An English lecturer looked at me when I wrote her prescription down as morbidly obese, and she said, "How could you ever think that you can write the word morbid against me in my prescription and hope that you're wishing well for me?" And I was stumped by how we are using some words which could mean something else in normal literature as scientific literature. And for you and me, morbid is a very common word. That's what everybody else is telling us to grade obesity as, but it comes with so much of stigma attached to this. So this was something which was implicit to maybe all doctors. We are not aware of it, but it was not deliberate. I was not hoping to send out signals of disease and death to her at all, but it took an English professor to point that out to me. So how do we move forward? What are some of the things that we can change? So one patient who's been seeing me regularly did say that, see, every single time, every doctor tells me is to lose weight, right? Now, it does not matter if in the last 2 months or 3 months, I've really worked out, I've really focused on eating healthy and I've lost weight. But if my weight is 98 or 100, whatever it is, at that visit, I'm always told to lose weight, right? So that is an approach where we are focusing on numbers, but probably a better approach is to focus on individual specific habits related to habit building towards healthier choices, right? So it could be increasing the number of days you exercise, or maybe reducing the number of binge eating episodes you've had this month, right? And what efforts your patient has put in towards building better habits and processes rather than focusing just on weight. So I might have gained 1 kg between last visit to this visit, but I might have exercised all days and I might not have had any binges at all in the last 3 months. So that is a visit where the patient must be congratulated than be admonished. So all of this put together, we have come up with this document called as Language Matters. Language Matters is a patient-led movement where patients came up and said, there are some of these words that you use which are harmful to us. So try and come and change. And Dr. Tejal, do you want to tell us how it's relevant to the Indian context?
Yeah, so much of what we discussed, you may think that, my patients don't experience this. I remember one person I spoke to, and they told me, मेरे patient मेरी डांट खाने सुनने के लिए आते हैं. They take my appointment so that I can scold them. So this is what most of us believe, that our intentions are good and our patients understand our intentions and they know that we mean the best for them. But we were shocked, and till today, sometimes the voices of these patients ring in my head because we'd recorded all of our research work, and I remember transcribing that entire 1 hour conversation, and those words still ring in my head. So what we did is that we did a series of focus group discussions across 5 states of India. We invited people living with type 2 diabetes, and we asked them to speak about their experiences with doctors, especially in the context of language, what words or phrases impacted them and did not impact them. And what we've talked about, the previous 2, one about elevated blood glucose and complications of diabetes or consequences of diabetes, and about obesity and diabetes, is just a snapshot of a lot of other things that we can change in the way we communicate with our patients. It's all put together in this document, which is called as Language Matters India. And this underlines the importance of language while communicating with people living with type 2 diabetes in India. I urge you, request you, that you must read this document, because when you hear what patients themselves say in their own language, you will understand what is it that we are trying to do here. And I think maybe also put aside being a doctor for a short period of time, and just as a human being, if you listen to this and you understand that we really need to speak with a lot more empathy and compassion than we are doing right now. Just one last thing I want to say, that this entire, document, this is in no way to say that doctors are not doing their best. But unfortunately, our medical training is not complete. We do not get any training in how to communicate a diagnosis, how to explain a prognosis. And because of this, we basically end up doing what we've seen our seniors or betters do. So I think it's time to kind of change the way we view, the way we speak to our patients. And small changes, I think, can make a huge difference in the lives of people living with type 2 diabetes.
And to say that most of the research was conducted or done with individuals from our clinics who were our regular follow-ups and whom we thought were actually happy with us. So that was one of the blows. So we were like, I thought you were one of the patients who was happy with me, but yet you were experiencing so much of hurt at our experience, at our encounters. So this was a very eye-opening experience for all of us. It's completely changed the way Tejal and I look at communication. We now introspect more. We now take a look at ourselves more and check in with patient responses, with their expressions, and how they're feeling. Most times, I strongly urge you to note the link below and get the document, because at the end of the day, we're all human beings and they come to us, they come to feel better, get better. And there's nothing else in life which is more powerful and not costly and the most underrated agent for human change as kindness is. With that, I'd like to have a special note of thanks to Dr. Mayur Patel and Dr. Mona Shah for giving us this opportunity to highlight some of the work that we've done and speak about a topic which is so close to our hearts. Thank you so much.
So Chitra, can we end by saying that instead of look before you leave, we can say think before you leave?
Thank you so much, Tejal ma'am and Chitra ma'am. Now over to chairpersons if you want to ask anything. Sir, please unmute yourself, sir. Arun sir, please unmute yourself.
Yeah, thank you, Divyang. It was an excellent presentation by Dr. Chitra Selvan and Dr. Tejal Lathia. I was really listening to each and every word they both were telling, and the basic comes first. So treating our patients not like the patient but our friends and our relatives makes a huge difference in the protocol and our ultimate outcome of the patient. So treating the patient with empathy, compassion, and the familiar way, and it is very basic and very important thing. A small change in our attitude can make a huge difference in patient's life. So ultimately our role is the helping the society and patients by and large by treating our patients and giving the proper advice. So excellent presentation, and I was really impressed by the presentation. Thank you.
Thank you, sir. And I just want to ask both the speaker that where would you put the focal group discussion in the line of management of type 2 diabetes? Because we doctors, we individually counsel the patient, but focus group discussion things are not going to happen in our routine day-to-day practice. So do you think that it should be again the part of the management of the patient with the diabetes?
Thank you, Dr. Arun Saxena, for those kind words. And thank you, Dr. Sushil Patel, for that question. So the focus group discussion which was conducted uh, was let's say, a research tool which we used to identify the areas which the patients had identified as lacunae as they experienced the whole journey of a consultation with the doctor. So it's a tool which we use for research to learn about what they thought, and the learnings from that is what is distilled and we've made a presentation out of, and also we are going to publish that in the form of a research article as well. Of course, conducting focus group discussions in your clinic might not be a feasible option, considering that the focus group discussion went on for about an hour and a half, and we had a qualified psychologist who led the discussion, who was there to record it and transcribe it. But of course, you and I can begin to pay attention to what our patients are telling us, collect feedback from our patients at the end of a clinic visit, pay attention to their body language, to their facial expressions when they're talking to us during our clinic. So let's say, for example, I show you my HbA1c report, and you say, oh my God, that HbA1c report is really high. And if I withdraw, or if I make a sad face, or if I talk less, that's a cue for us to understand that our patient is not probably liked that bit of a encounter. So, focus group discussions to hold in clinical practice are an absolute stretch of an imagination, as you've rightly pointed out. But we use this tool to learn our lessons. The feedback which we get from our patients can be much shorter and more distilled, and is something that we can learn from all the time.
Thank you, ma'am. Just I want to add something that we at the Swasthya Diabetes Care at Ahmedabad, we have that on the each and every day with the family members of the patient and the patient themselves. We have the discussion for 1 hour in which we educate the patient, and for the 15 to 20 minutes after that lecture, we have the focal group discussion with each and every patient and their relatives, and that make huge impact in the management of type 2 diabetes. So again, thank you very much. Thank you, madam. And
Thank you.
So Dr. Mayur Patel here. At the outset, I congratulate Chitra and Tejal. Excellent work and very good presentation. I want to share my feelings or my comments because being practicing in the tertiary care, good versus truth. Many a times we have to tell them truth rather than, but of course in a milder language rather than harsh language. I do agree with you, but at least we have to tell them they are suffering from kidney disease, or maybe they are not going to comply, then they may get the heart attack, or there are chances of heart failure like this. And many times you must have noticed in your practice कि VIP पेशेंट आते हैं तो उसको क्या होता है कि कोई बोलता ही नहीं क्या है, तो सभी अच्छा अच्छा ही बोलते हैं. एटलीस्ट वी हैव टू टेल देम रियलिटी कि ये ध्यान नहीं रखेंगे. कई लोग तो मेरे को अप्रिशिएट करते हैं, सर आप आपके साथ आते हैं ना, अच्छा है, डांटते हैं तो जिंदगी में किसी ने मेरे को डांटा नहीं है. तो आई एम नॉट नोइंग द राइट वे टू लीव और राइट वे टू काउंटर द डिजीज. सो विसाविस, what is your experience? Tejal and Chitra, you may tell.
So, sir, this is what feedback we got from most of the doctors when we spoke to them. That I scold my patients, and I remember this one patient I scolded. Next month he came and his HbA1c was normal. This is an experience which most doctors tell us. But what happens, sir, is that when we are in a busy practice, you remember the patient who came back, but you don't remember the 9 patients who actually got scolded and never came back. And this is in no way a criticism of any of the doctors. I have been there and done that, and I have done all these same things that we discovered that we shouldn't be doing. So yes, there could be that one patient who really needs that scolding to kind of get him on track. But I think 90% of the time, just by talking kindly and acknowledging the problem and speaking in a compassionate way, I think we can get the job done. Just one last thing I want to say, and this Chitra and I were talking about it. See, sir, what happens is that we had a conference on Sunday about this. See, when we are rude to our patients, we get angry, our own blood pressure goes up, we are irritated, we get stressed out. And then at the end of the day, when we go home in a negative frame of mind, having raised our blood pressure and our heart rate throughout the day. So not only from the patient's perspective, but from our own perspective, I think anger and scolding takes out a lot of energy from us, and we should conserve that energy for better things.
With the permission of the chairpersons, I'd like to come in and add to Dr. Tejal. So when you talk to psychologists and therapists, they looked at patient encounters completely differently. Only physicians, diabetologists, and endocrinologists seem to think that it is their business to herd their sheep being patients. मेरे बच्चे अच्छे से परफॉर्म करेंगे, मेरे बच्चे का HbA1c अच्छा रहेगा, मेरे बच्चे मेरी बात सुनेंगे, ऐसे.
Right.
But therapists don't work like that. Therapists only want you to figure out the answer yourself within the constructs of a healthy relationship with your own sense of self. I think that's where they win, because if they tell you do this, this, and this, you don't need to go to a therapist. You can just go to your mother-in-law or your mother for that matter. But a therapist points you towards what is a healthy choice and allows you to discover that choice by yourself. I think there's a lot that we as physicians can learn from them. We can't change grown adults. And even scaring them might not be as beneficial as we think it might be. Maybe we should design a study, Tejal, to maybe point out if this works or not. We should maybe do a randomized control trial, scare tactic versus kindness, and see how HbA1c's change after that. Thank you for that insight, Dr. Mayur Patel. Thank you so much.
Thank you so much.
I would like to ask you, isn't it like a balance of, showing some fear and compassion both at a time? That can work out in a better way rather than taking one stand, like being liberal to the patients and allowing whatever they want to do with their lifestyle, with their diet, with their medications, and talking like in a very bizarre way. Isn't it there should be a combination of compassion with bit of fear, because being a scientific person or being a a doctor or a clinician, we have to many a times tell them the facts that what they are facing and what they are going to undergo in a future time. So maybe it's my point.
One last my small comment, because cardiovascular cardiologist versus diabetologist. Cardiologist may act like Hitler,
Right, sir.
and diabetologist must act like Abraham Lincoln.
Thank you.
That's a difference.
Thank you so much, Mayur sir, Chitra ma'am, and Tejal ma'am. Now we need to move on to our next session.
Thank you so much.
Yeah.